I'm Timothy Donahue. I am a professor in the Department of Surgery and the chief of the Division of Surgical Oncology at University of California, Los Angeles. So the question is about a primary pancreatic tumor that appears resectable. What burden of lymph nodes or questionable lymph nodes would be too high to offer surgery? And this is assuming that it's a localized tumor and has not spread elsewhere. So I think the first point to make in relation to this question is if you look at all patients who have undergone surgical resection for pancreatic cancers who have not received upfront chemotherapy or upfront treatment, about 70 to 80% of them will have positive nodes. So it's the norm, majority of tumors that are resected wind up having positive nodes in patients who have not received treatment before surgery. In patients who have received treatment before surgery, chemotherapy, occasionally radiation therapy, the percentage is much lower. It's usually somewhere around 40 or 50%. That's potentially due to whether a patient selection, patients who progressed during treatment that didn't maintain their surgical candidacy, or perhaps the treatment is eradicating the disease within the lymph node. So I think when we think about this question, we have to think about that it's a large majority of patients who have not received treatment do have positive lymph nodes at surgical resection. So, and then the other thing is, and we've looked at this, most tumors in the pancreas occur in the head, and most patients present with biliary obstructions. The bile duct being obstructed in and of itself can cause the nodes to become enlarged for non-cancerous reasons. And so, you try and think about a similar or a parallel situation, whether it be gastric cancer or esophageal cancer, where, there are radiographic size criteria to determine whether or not it's thought that nodes are positive. It's hard to translate those to pancreatic cancer just because the nodes can become enlarged or malignant appearing, not only because they're they're involved with tumor, but also because they can become enlarged because of biliary obstruction or a lot of inflammation that occurs around the head of the pancreas when a tumor is present. All that being said, in general, what we usually use as a rule of thumb for nodal enlargement or suspicion of nodal involvement in determining surgical candidacy is if the enlarged nodes are within the field of resection, then we don't see that tumor as being unresectable or prioritizing chemotherapy or systemic therapy before surgery for those patients. If there are enlarged or suspicious appearing nodes high up in the porta hepatis, by the liver, or down by the celiac axis, or even into the small bowel mesentery near the uncinate process of the pancreas. Those we consider to be more outside the field of resection, and those patients we think that should receive upfront treatment rather than to go to surgery first. So all in all, most patients with pancreatic cancer, when they present, have nodes positive. The nodes can be enlarged for both malignant and non-malignant reasons. And the rule of thumb that we use for the most part in determining a surgical candidacy and whether or not a tumor can be resected up front is nodal enlargement or suspicious nodal positivity within the field of resection is what's considered to be acceptable and have patients still be eligible for an operation. We don't look at nodes all alone. We also look at the CA19-9 tumor marker, and consider that, in conjunction with the lymph nodes. If the bilirubin is normal, I think that the relative cutoff in CA19-9 that people use in order, if a tumor looks like it's localized and doesn't have nodes outside the field of resection, isn't metastatic, for the most part is 1,000. That's the current ASCO guidelines, where, if a CA19-9 is above 1,000, we consider those patients to be at least biochemically advanced and start their treatment with chemo or radiation rather than surgery up front. And so nodes don't tell the whole story in and of themselves. And we, kind of take the whole picture into consideration, which is another point, good point why it's important for these patients to be discussed at, multidisciplinary tumor boards, and, have input and consultation with not only surgeons or surgical oncologists, but medical oncologists and other experts who treat patients with pancreatic cancer. So, the right or the best decision can be made for these patients to optimize their survival.